Hello, everybody. Good morning, good afternoon, good evening, wherever and whenever you're joining us from today. Welcome to another episode of the Coach's Corner. Woohoo! Episode 53 with Dr. Carlos Grandella. Super excited to chat with him today. Before we jump into uh, the main part of the show, I'm going to go ahead and let you guys know that we will have a little bit of Q&A towards the end of the session. So if you have any questions throughout the conversation, make sure you put them in the chat box, okay? And we'll have someone read the questions out to us and answer them accordingly. But again, we will have that Q&A towards the end of the session. And then also for those of you out there who are users of Iris Vision, thank you so much for being part of the Iris Vision family. If you have any questions regarding your device, you can always call in to the customer support line. All of our customer support reps are awesome and they're ready to help you with any questions you might have. If you are not a user of Iris Vision, but you've been kind of thinking about it, do call in to our sales line, and an awesome sales rep will be more than happy to answer any questions to see if you're a good fit for Iris Vision. That phone number is 855 207 6665, and you could press 1 for sales or 2 for support. All right, so let's jump right in. Dr. Grandella, thank you so much for joining us today.
Absolutely. It's a pleasure, Myrna. Thanks for having me.
Yeah, I'm excited to kind of learn a little bit more about what you do and um, learn a little more about these different eye conditions. Of course, people always want to know, what's going on, or maybe it's a loved one that's watching the show and doesn't really understand what their spouse or parent or sibling or, family member or friend is going through. So hopefully this will give people a little more insight.
Absolutely. A lot of people who come in for a low vision consultation with me, they have a hard time understanding what their condition is and what that means for the future. And they'll talk about a variety of symptoms, and it's often there's a disconnect between what the condition is and why it's causing the symptoms that it's causing.
Right. And one of the biggest eye conditions out there is age-related macular degeneration, especially with like the baby boomers, getting older,
Mhm.
getting up there in age. They're starting to experience some, funny stuff going on with their eyes. So could you explain the difference between wet and dry age-related macular degeneration?
Absolutely. So as an optometrist who specializes in low vision, I see macular degeneration all the time. It's pretty common here in Arizona. Part of that is the bright sun that we get out here, demographics, things like that,
Right.
make us more prevalent for macular degeneration here. But I am not a retina specialist, so for those who may go and see a retina specialist, an optometrist is not somebody who does surgery. A retina specialist would be a medical doctor who specialized in ophthalmology and then went on to
Mm,
do further training in retina. So they're hyper super specialized and
okay.
really for macular and for other retinal conditions, that's who you want to see. Because if we do have to do some kind of a procedure, they're the ones who are going to do it. Now, in early stages, you might be fine with, general optometrist or ophthalmologist, but so macular degeneration or age-related macular degeneration, also called AMD or ARMD, is a condition usually crops up late 50s, early 60s, somewhere along those lines. And it's essentially a buildup of waste material in the retina that causes damage to those cells that collect and receive light and transmit that info to the brain. And that happens most predominantly in an area called the macula. The macula is the kind of center back portion of the eye. One way to think about it, I'm going to grab my eye model actually. I'm thinking that might be helpful.
Yeah.
For those who are able to see, if we have a model of an eyeball, the very front part of your eye, the clear part is called the cornea. If we were to open my eye model kit here, So the cornea would be that clear plastic layer at the beginning. Inside that is a little bit of space filled with fluid, and then we get to your iris, which has all the color, and the hole in the middle of the iris is the pupil. That's where the light comes in through. So if we take that part out and we pass through past our iris, if I can get this guy open, just past the iris and the pupil is the lens. And so that's where cataracts can form. Cataracts are a death of the lens in the eye. After a certain amount of time, it just starts to cloud up because the cells that are in there start dying off. And there's a few different kinds of cataracts and why that might happen, but those are also age related. Just past that cataract lens, your whole eyeball is filled with kind of jelly. We call that the
Mhm.
vitreous. Some of it's liquid, some of it's jelly, some of that changes over time. And when that changes, you can get floaters and things like that happening. So we don't get to the retina until we get to the very back, very inside part of the eyeball. So I think about if the eye was like a satellite dish, it's that inner lining of the dish that is the retina. So all of the light is being collected back there, but it has to pass through all these different structures. Many people have conditions involving those different structures, like cataracts. So by the time we get back to the retina and we get to a highly specified portion called the macula, which is where all the very sensitive photoreceptors are, the cells that transmit light. Um, we get this buildup of waste material in that area because it's high production. It's just going, 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 making and producing things. When that buildup of waste material happens, the cells start to decay. And if they decay quite a lot, it can lead to bleeding inside the eye. And that's the difference between the dry form of macular degeneration and the wet form. So a lot of people confuse that with dry eye. We're not talking about tearing and wetness on the outside of the eye. This is all inside the eyeball. And
Oh,
both
okay.
versions can lead to central blindness. The goal with treatment is to prevent that as much as possible. Some cases we can't prevent it, but the wet form gets there much faster. So it's like the tortoise and the hare, they're running the same race, but the hare's just going to get there a lot faster if he does what he does. And so if we let that wet form run rampant without treatment, instead of being a matter of months to years progressing slowly with the dry form, it could be a matter of weeks with the wet form. So very important that we see the retina specialist, that we manage this condition well.
Right, and you mentioned treatments, so that's perfect. I was going to ask what treatments are out there, or maybe lifestyle changes that someone could start implementing that might help slow the progression of macular degeneration, age-related macular degeneration.
So we think about macular degeneration as if it was just one condition or just one problem, but the fact is most conditions are a spectrum and they just seem
Mm.
to fall within a category. So we say, well, that's what this is. Macular degeneration, age-related macular, has several different causes. There are genetic components to it. There are lifestyle components like smoking. People who are
Ah,
smokers are more likely to get this. Um, UV light exposure, so not wearing sunglasses, getting exposed to a lot of UV light. It's part of why it's more prevalent in Arizona, we would say. But
mm.
there's also a metabolic factor or a nutrient factor, which is why we have a supplement. It's called AREDS2, AREDS2, that stands for the Age-Related Eye Disease Study, number two, where they figured out that this certain formula of vitamins was preventative in further progression. So the original study said it was about 20% effective. So people who had that vitamin supplement were 20% less likely to progress to the wet form. And not a lot of downsides to it. It costs a little bit extra money. There's lots of brands out there. People might know PreserVision or MacuHealth, but if they say AREDS
Okay.
2 on the label, it's essentially the same formula. Now, here's where I would go back to your retina doctor and say, is there a certain brand that's better? Because some of them have additives that are bad. Some of them have additives that you may be allergic to, like preservatives. Some of them throw in additional things we found, other studies that, well, more lutein may be more helpful to you, or antioxidants may be more helpful. And some retina
Mm.
doctors do their own in-house studies, and they'll see, better results with one versus another.
Right. I know that a lot of people ask about vitamins and things like that, but just as you said, it's important to talk to your retinal specialist. And because of those fillers, sometimes those over-the-counter vitamins from, major stores could have a lot of fillers. So it's a good idea to really understand what type of vitamins uh, are appropriate for the eye condition, and also what type of vitamins are appropriate for you, right?
Absolutely. Because you don't want to double up. Some vitamins can be toxic if you take them in large enough amounts. So even talking to your primary care doctor as well, if you're taking multivitamins, could be a smart decision. Now there is one other thing came out. There was a study came out in June, so it's pretty new information. They did a retrospective look at over 100,000 patients and progress over years, people who had macular degeneration and were not taking melatonin. And they found that those who took melatonin were less likely to progress. So this is not a randomized clinical trial. That's usually what we base our treatment off of, is we take 100 people, 1,000 people, and we say, we do this to them, and then we have a group we don't do anything to, and we compare them. How many got better? How
Mm.
many got worse? So this was just, we looked back at records, and not we, I wasn't a part of it, but excited to learn about it. And they
Yeah.
found that melatonin was helpful. So that's something, again, I would
Oh,
take to your retina
cool.
specialist and say, hey, this is helpful. Is there any reason I shouldn't do melatonin?
Right.
And maybe talk to primary care about that too. And but yeah, anything we can do to save the vision is probably a good thing to do.
Cool. So I know that there's probably so much more that we could talk about when it comes to age-related macular degeneration. But in a nutshell, that was a really awesome overview of what that is. Thank you so much. Let's move on over to Stargardt's disease. Okay.
Yeah.
So could you kind of explain what Stargardt's is, what you know of it anyway, and how that vision loss progresses?
Yeah, so Stargardt's this is a good jumping off point because Stargardt's has also been called juvenile macular
Right.
degeneration. And so we said that age-related is going to start in 50s or later. Stargardt's can start as early as childhood. And so this is a similar problem, but for different reasons. So it's also a buildup of waste material. This one specifically called lipofuscin. With macular, you get a different kind of buildup. But so we get these deposits of waste material that then later accumulate in the center of the retina and the macula and then cause widespread atrophy and destruction of that same macular area. So if you have somebody who's advanced in Stargardt's, they might have the same problems as somebody who had macular degeneration, but just for different reasons. So in both cases, we might have center vision loss and good peripheral vision. So you might
Mm.
be able to see a person's body but not see their face, kind of a deal. So with
Right.
Stargardt's, this is caused genetically. This is something that you can have genetic testing for. You can go through, there's a few nonprofit groups that run free private testing, or you can also often do it through your medical insurance and isolate exactly what gene do you have that's causing this. So again, this is a spectrum. There's ABCA4 is the typical gene that's causing this, but there's a lot of different ways that ABCA4 could get mutated. And so for some people it's missing, and for other people it's the wrong code, and for other people something else got put in instead. And
Mm.
some of the groups that are doing this testing are monitoring that to say, well, when it does this mutation, we see it progress like XYZ. It happens early or it happens late. So they're actually currently working on a clinical trial to
Mm.
rewrite some of the problems that come from this mutation. So genetic testing is a new thing. Um, well, not genetic testing, but genetic therapies are a new thing for
Oh,
eye
okay.
disease. 2017 was the first gene therapy for an inherited retina condition, and that was wildly successful. They're currently working on a few for Stargardt, so we're very excited to see where that will go. And if you have the right versions of it, it could be applicable to you. But it essentially will halt the disease. If you've already had
Mhm.
progression in the past, you've already had decay in the retina, it probably won't restore anything. But for, somebody who's newly diagnosed, that could be life-changing for them.
Absolutely. I don't think I qualify for that. I have Stargardt's disease, and I don't think I would be a candidate for that because I'm pretty sure my retina has deteriorated. I'm sorry, my macula has deteriorated pretty, pretty much to the point of that's that's all, folks, for mine. But I mean, who knows? With that knowledge that you just shared about getting the genetic testing done from, different nonprofits or maybe even through the health insurance, who knows? I'll give it a shot for sure.
And that's something that a retina specialist or myself could do. So I work with one of the nonprofits who does it for free. Is we mail a kit out to your house and you spit in a tube, and a month later we find out what's going on. But there have been some. So I was at a conference last year. University of Colorado was working on retina transplantation, and so they've been able to
Ooh.
grow a retina in a petri dish and put it in an animal eye that was scarred in a similar way to macular or Stargardt's. And so they think there's several years out before they can test that in people. And there's a lot more to it. They have to figure out to make it as good as your macula might have ever been. But
Mm.
there is active investigation going on in all of this.
Well, that's exciting. So, I think someone's not muted. Yunjin, if we can get them muted. But that's great to know. So, what are some of the signs and symptoms that people should look out for when it comes to Stargardt's disease? Because I know what I went through as a young person, but I'd like to hear your thoughts on that.
I mean, top of the list is going to be blurred vision that isn't corrected with glasses. That's pretty widespread for most inherited conditions where we're going to
Mhm.
lose some of the center vision is we're going to get blurred vision. We're going to start sitting close to things. A lot of kids are going to be holding phones and iPads close. Now we may struggle with some of that already. That's just natural behavior. But for somebody who has vision loss, they're going to do that to magnify. And it's going to be a very hard habit to break. And so, if anybody's doing that, it would be a really good idea to have them go have an eye exam and determine, do we have a lack of vision going on? Other concerns we might see would be reduced depth perception. So that could lead to clumsiness, tripping, things like that. Sensitivity to glare. So that's across the board for retina conditions as well, because once the structures get damaged, if they're getting light, it doesn't mean they're totally off. They might be misfiring. They might be sending
Mm.
information that's aberrant and causing more problems than help. So glare and light sensitivity can be a big sign as well.
Gotcha. Yeah, for me, when I was experiencing the initial, I guess you could say, signs and symptoms, looking back now, I wasn't making complete eye contact. When my
Yep.
mom would talk to me or something. Okay, my mom will probably kill me for saying this, but when she would scold me,
Mhm.
she would say, "You look at me when I'm scolding you," and then I'm like, "I am. I'm looking at you."
Right?
But apparently, my eyes are off to the side a little bit. So that
So
was
that's called
something.
eccentric fixation, and that's a pretty common thing for anyone who grows up with a condition. For our senior patients, we're often teaching them to do that because it's a very
Right.
helpful adaptation. If your side vision never gets affected, well, moving your eyes off to the side to use that is a great strategy, and kids will get wired to do that from the beginning.
Oh yeah, when I first went to the School for the Deaf and Blind here in
Mhm.
Arizona, they were just like amazed on how quickly I picked up on using the eccentric viewing or eccentric fixation, and how I was just quick to adapt to like the assistive technology like CCTVs and things like that. But I was a young person, so it was a lot easier for me to learn that stuff then.
Yeah. If you're motivated, I think it's easy to pick up a lot of this, and a lot of kids
Right.
are motivated. Yeah. Because they want to drive, they want to read computers, they want to do books. They're just excited to be a part of everything.
Right. So that's a really great little summary of Stargardt's disease, and that's something obviously that's close to me because of the fact that I actually have it. But another condition that actually I have as well is RP, retinitis pigmentosa. Can you kind of tell us a little bit about retinitis pigmentosa and how it differs from macular degeneration?
Yeah, so RP is another inherited retinal condition. And this one kind of works opposite of what Stargardt's is going to do. So this is going to work on the outside of your vision and many times leaves the center alone. So to have both of them sometimes can be very devastating, but each
Yeah.
one, again, it's a spectrum. So not everybody who has RP has the same level of problem as everybody else. So some patients do go completely blind from RP. As a general rule of thumb, the earlier you get diagnosed, many times the worse it is long term. But so there are different genes that cause RP. One of those genes, RP, I want to say it's 365 or 65. I always forget that part. That is the one that has a gene therapy for it. It's called Lucentis. Um,
Oh.
no, no, I'm sorry. I'm mixing that one up. That's one of our macular ones. It's Luxturna. So this is why I don't give the injections. So Luxturna was came out in 2017, and that is
Mhm.
the gene therapy for that specific kind of RP, and will halt the disease in its tracks. So RP, we have this decay of the outer retina. The major symptoms we'll get will be side vision loss and night blindness. So night blindness is sometimes the first thing we notice, but I've had several kids who come in and parents will say, well, yeah, we don't really know what's going on. They seem to be really clumsy. I had one in particular said, well, she's fine, but every time she gets on a bike, she just falls right over and like it's like she has no sense of where she is in space. And it was true because she didn't have side vision. She didn't have a sense of where she was in space. But night blindness is a big part of that, loss of contrast. But interestingly enough, blurred vision is not always a problem. I've had several cases of RP where someone might have 20/20 vision, but they have it in a very small field or a very small
Mhm.
window of vision. So if you heard of tunnel vision, this is a disease that would cause that. So for example, I had a gentleman, we'd have a conversation about driving because he had only about 30 degrees of vision. So that's a pretty small area. You should have something like 120 degrees in each eye individually. But within that 30 degrees, he had 20/20 vision. So he felt as long as he moved his eyes back and forth, he was able to do everything, very easily. Some
Eh,
people have a hard time scanning and they never learn those tricks. And so they find they bump into things and over things and trip and need an orientation and mobility cane to help. And so, yeah, RP, quite a different condition, but also genetic. Another one worth doing testing for.
Absolutely. And there's some pretty good treatments out there and studies, right, for RP, as you mentioned. So, is it the same thing? Like, if someone wants to get uh, tested for RP, can they just go to these nonprofits and get the same
Absolutely.
type of genetic test?
Absolutely. So I would say in Arizona, you can call my office. If you have a retina specialist, most of them will be able to take care of it. But there are a few doctors who do more inherited retina than others do. But yeah, there are many clinical trials that go on for RP. That's one of the bigger conditions as far as inherited retina conditions go. And so there's a lot of effort towards finding cures for that. So there's a lot of trials that once you have genetic testing done, you know what kind you have, you can participate in clinical trials if you want to. Some people don't want to be a guinea pig, but some people want to
Mhm.
do everything they can. If you get access to something that helps you sooner than you would otherwise, then that could be a big benefit.
Absolutely. So thank you so much for that little sum up of retinitis pigmentosa. Let's move right along to diabetic retinopathy. So,
Right.
can you kind of describe what diabetic retinopathy is and
Yeah.
how people, end up with it?
So diabetic retinopathy comes from diabetes. So diabetes, there's a few types of it, but ultimately diabetes is a problem with the level of sugar in your blood. Now, that may be from not producing insulin in your body. That may be from too much insulin in your body getting resistance to that insulin and what it does. That's involved with, when you eat something, your body takes the sugars out of that, puts it in your bloodstream, so it can carry it around to where it needs to go in the body. And there's hormones like insulin and glucagon that take sugar in and out of your bloodstream. That's a very simplified version of that. So please, no medical doctors get mad at me about that. But
Right.
essentially, if there's too much sugar in your blood, it gets thick and viscous. And so it pulls along the blood vessels as it's going and can cause tears and holes and damages and things like that. And so, um, your eyeball is often the easiest place for us to look inside your body and see what diabetes is doing. Because if it's causing problems in the eyeball, it's causing problems everywhere else too. And those problems usually
Right.
take the form of what's called a microaneurysm or a very small bleed. And we'll look into the retina and we'll see these little pin marks, little red pin marks everywhere. These are little micro bleeds that are happening because the high sugar in the blood is causing damages to the arteries and veins. And so, in early stages, this is easily reversible by getting control of your blood sugar, whether that be a medication like metformin or it be diet and exercise, or everybody talks about the new Ozempic and drugs like that. That's between you and your primary and your endocrinologist to figure out what's the right choice for you. But getting control of blood sugar is very important, because if we don't control it, those hemorrhages get bigger. They can lead to things like blood clots, so we can have an occlusion of blood vessels. We can get retinal detachments. We can get what's called neovascularization. So
Mm.
when those vessels are clotted and damaged and blood is not going where it's supposed to, the body kind of says, "Hey, I'm not getting blood where I need to get it. Can we make a new blood vessel to get blood to me?" But the body's very bad at making new blood vessels, and when it does, those are leaky blood vessels that cause many more problems than help. And
Uh,
so neovascularization is a big problem with diabetic retinopathy. Um, all of this can culminate in other conditions like glaucoma, can lead to cataracts, can cause complete blindness just from diabetes. So, if you think just having a little high sugar isn't that much of a big deal, being a little overweight's not that big of a deal. I have had patients who've gone completely blind from diabetes. And so I can't stress enough that early action leads to really good long-term results. Because the longer you have diabetes, the more likely you could get a complication even under good control. So maintaining
wow.
that good control early is really, really important.
Yeah, absolutely. And that I was actually going to ask you what are some like preventative measures or things that people can do to kind of lower the risk of uh getting diabetic retinopathy. And you already touched on some things in regard to making sure you keep up with your doctor, your endocrinologist, and then also maybe taking a look at your dietary and lifestyle um
Absolutely.
habits, right? You want to make sure you have good eating habits, you have a nice little exercise routine going on. And exercise tends to help across the board as well, right, Dr. Grandella?
I mean, in general, is a great thing to do. There's lots of
Mhm.
things that affect your general health. Blood pressure is a big part of that. So many times when blood sugar is out of control, pressure can be out of control. Pressure leads to things like strokes, and you can have a stroke in the eyeball. So maintaining your systemic or your whole body health is important to the long-term viability of your vision. I've got somebody knocking on the door. They've got a quick question for me.
Sure,
I'm,
sure.
can I take about 1 or 2 minutes? I'll pop right back.
Sure, no problem.
Thanks so much.
So, Dr. Grandella has been sharing so much awesome information with us today. And for those of you who maybe didn't understand what was going on with your eyes or didn't have a lot of knowledge about your AMD or your Stargardt's, your RP, maybe your diabetic retinopathy, hopefully this has kind of helped you along the way to understand a little more about your eye condition And as he was mentioning several times throughout the interview, to make sure you follow up with your retinal specialist, with your eye doctor, with your primary care physician, and make sure that you're taking every measure you can in order to keep your eyes as healthy as possible. Because, I mean, me myself, I have Stargardt's disease, so I totally understand what it's like to be in those shoes of, having the sight loss and going through the deterioration of the sight progressively. Even now, fast forward 30 years later, I'm 42. I know that I was able to see more when I first started losing my sight to where I am now, in life. And it has to do with a lot of things, just like Dr. Grandella said. It's high blood pressure. I have high blood pressure, and exercise and eating. All these things are factors, and it can be tough, but it is important for, overall health, whether it's visual or just physical health or whatever it is. It's important to, keep that routine of good eating habits and exercise. And trust me, I'm guilty of not always sticking to that because it's tough. But if you, care about your vision, you might want to kind of take those things a little more seriously. And I'm kind of pretty much preaching to myself here, um, just because I do tend to have a little trouble in that area. But with this awesome information that Dr. Grandella has shared, hopefully it helps all of you out there listening right now. So, Dr.
I'm back,
Grandella,
Meredith.
yes, let's go ahead and wrap up with cataracts. We did mention this quite a bit. We sprinkled it in throughout the whole interview, right? Which is great because people tend to have questions about cataracts. Now, cataracts isn't necessarily considered a low vision disease, right? It's
Correct.
just something that happens to the eyes. So the thing is, sometimes when you do have macular degeneration or RP or anything like that, it could kind of affect the way the cataracts are treated. Is that correct? Am I kind of going?
Absolutely. So cataracts again are a clouding of the lens that's inside the eye. Without another condition going on, cataracts will happen because of age, typically somewhere in the 60s or later, and they
Mhm.
just start clouding things up. And when they first start, there's really not much we need to do about it, but eventually it hits a point where it's affecting your vision, affecting your contrast, your glare, and your color perception. It'll make blues and yellows much harder for somebody. So when we get to a point that it is actually affecting things, that's where medical insurance will pay to have a surgery done to take that cataract out. So they go in and they break up the little lens inside the eye and they take it out and they put in a new artificial lens. And that's about a 20-minute procedure, usually pretty uncomplicated. Um, so on its own, not that big of a deal. My mom had cataract surgery, I think, 2 summers ago, and
Okay.
had a great result for hers. The problem we get into when we have any other eye condition is we have to weigh up, will doing surgery on the eye affect the well-being of the eye, like causing more atrophy or causing a change in pressure, which is important for glaucoma? Is there anything fragile like a retinal detachment that could come off by a change in pressure? Some of these conditions also cause earlier cataracts. So, like retinitis pigmentosa can cause early cataracts. I had somebody, I want to say a week ago, early 40s, had cataracts because of RP. Diabetes can also cause early cataracts. In this last month, I saw a traumatic cataract. It was somebody who bent down, got hit in the eye, and had a cataract because the blunt force trauma was so strong.
Oof.
Um, so lots of different reasons why we could get them, and sometimes problems we get after them. So those who do have complications with cataract surgery usually come in the form of, number one would be an infection. That would be the worst one we could get. Somebody sneezed in the operating room, or there was a tool that wasn't perfectly sanitized, or there was something in the eye that's there naturally that got inside. And once it gets inside, it can wreak havoc. There's all kinds of reasons why this can happen. That's called endophthalmitis. Endophthalmitis could completely destroy the eye if it's not caught fast enough, and we have to catch that like within 24 hours. You know, it's a very
Oh,
important kind of thing. So when somebody has cataract surgery, they always have a 1 day post-op to check on those kinds of things. So that would be, one issue. Another issue could be swelling inside the eye. That can happen after cataract surgery. And then we also get issues like many of my patients with macular feel like their macular progressed after cataract surgery. Now,
hmm.
sometimes that's maybe true, sometimes that's not. And part of that is because macular is a time-based thing. And so whenever that progresses, if there's an event that was around the same time as your progression, it's going to feel like those are connected. Can that actually happen? Absolutely. You're changing where things are positioned in the eye. That can affect the whole health of it. There's some studies that show some links to macular progression. However, I would also point at your perception of your vision is much different after cataract surgery. With a cataract, everything is blurry the whole time. Peripheral, central, the whole thing.
Right.
Once you take that out, the periphery will get a lot better, but if there's heavy macular damage, the center stays the same. So you're much more aware now of the difference between those areas. And I feel like that's the biggest thing my patients are noticing is that, well, yeah, I did that surgery and now, like, yeah, I had this good side vision, but all I can think about is this muddy spot in my vision the whole time.
Yeah, because they got used to seeing with the cataract and now it's gone,
Mhm.
so now they have to get accustomed to seeing in a different way. Yeah, that makes
And you
sense.
add to that when you do cataract surgery, they take your glasses prescription and put it inside the eyeball. And
Oh,
so that can be both for good and for worse. If you have a very high prescription, that can be really nice. But somebody who, like myself, I'm nearsighted just a little bit. So I don't have glasses on. I actually see pretty well up close. I would lose that ability after doing cataract surgery.
right, right. So, a lot of different uh ways to take care of your cataracts, guys. Definitely, again, talk to your retinal specialist if you're noticing that cloudiness, like Dr. Grandella was talking about, and get those peepers checked out. Make sure you keep them healthy,
Yeah, I would
right?
say our
So,
recommendation is a once a year dilated eye exam.
ah,
If it's progressing, as soon as you need to get in, I'm never angry for you to come in and see me. You're never seeing me too often. The last thing I want is for you to come back 6 months later and go, well, yeah, it got worse, but I didn't do anything. And then we see, yeah, we go from maybe 2100 to 2200, or
ah, yeah.
you've only got two eyeballs. Please take care of them.
Yes. So, last question here, Dr. Grandella. In your experience, what has been the most common misconception about having a low vision disease?
Ooh, um, there's a lot of them. There's a lot of ignorance with vision loss, and so that, both on the part of medical staff and the part of family members, the part of patients themselves. Um,
Mhm.
so there's, a few different names for low vision, and going back to why cataracts don't count technically as a low vision condition, is because low vision is defined as a vision impairment that is not
Mhm.
fixable with glasses, contact lenses, or surgeries. Cataracts would be a surgery. And so, that's something that, yeah, it's fixable technically. If you have other conditions too, well, there's more going on with that. But
Right.
low vision, also called vision impairment, many cases also called blindness. You could be legally blind, you could be functionally blind, you could be totally blind. Some people who are
Mhm.
considered blind still see, shadows and shapes, still see when the lights are on and off. Um, One of the biggest problems I think about low vision is lack of public awareness. For a
Yes.
lot of people, there's no way to look at them and know that they have a vision impairment.
Right.
Unless you're watching how somebody acts or you talk to them about it. A big problem a lot of my patients say is my friends come up to me and say, hey Bob, how you doing? And I don't know who they are because I can't tell who they
Right.
are by their voice. So advocacy on the patient's part is a big help to lifestyle, but is also a big burden for a lot of people to have to tell people all the time, hey, by the way, I can't see you, tell me who you are. Or some of our patients will wear a button or something like that says I have vision impairment, or using a mobility cane. That could be one of the bigger misconceptions is use of a mobility cane. When I say that, that's the long red and white cane, the foldable cane that people will use when they have vision impairment. Many people think you need to be legally blind or completely blind to use a cane, and many people get harassed because they might have
Yeah.
some vision but still be using a cane. A cane is for any person who feels uncomfortable, unsafe walking independently because of vision loss. And the idea with
Right.
the cane is it's going to give you your touch feedback for, is where I'm walking going up or going down? Are there cracks in the street? Is there something I'm going to trip on? Many people need that help. Even if all you've lost is your depth perception, you might benefit
Hmm.
from a cane. It's also
Absolutely.
a great advocacy tool. When people see that, they know what that cane means. I would
Mhm.
encourage more people to have cane training than those who currently get it. Many people wait until they have to use it. I would encourage you to get that training early so that if should you ever need to use it, heaven forbid, but should you ever need to use it, you'll already know how. And you can make the choice of,
Sure.
well, maybe I'm going to take it out in the airport, but I'm not going to use it around the house. Or maybe I'm going to use it in the grocery store,
Right.
but I don't need it at church where I know where everything is. Not everybody uses a cane, uses it 24/7.
That's true. And I'm one of those. So I definitely have my cane and I use it from time to time, but not always. But just where my site is right now, I think it'd probably be a good idea for me to start thinking about using it a little more often when I'm out in public. And really not so much for me, but for others' awareness as well. So thank you so much, Dr. Grandella. I really appreciate all this awesome information that you shared with us. So I'm going to go ahead and wrap up with like a coach's tip for the Iris Vision Live 2.0. I know that you have one of those in your office, right, Dr. Grandella?
Yes, ma'am. In fact, we've got one
Mm.
in each of our offices. We've got a couple
Ah,
actually.
perfect. Cool. So, when you're using Iris Vision 2.0, a lot of time people want to know what the voice commands are. They want to be able to use the voice commands, but they want like a little cheat sheet of the voice commands. I'm asked this all the time as a coach. One of the things that I like to suggest to people is to go through the menu for each individual mode. So if you want to know the voice commands for the welcome mode, that first screen that you're in with the big E and the blue eye and the yellow word focus, just press button A on your remote control and then use the little joystick on the remote. Hopefully it works here. Use this little joystick on the remote to navigate through the menu, and every single option in that menu, regardless of what mode you're in, is an actual voice command. So that's a really cool way to get familiar with the voice commands for each individual mode. And if you adjust contrast, brightness, field of view, whatever it is, if you adjust these settings so much so that you don't like the way it looks, it's okay, because the last option in every single menu or most of the menus is reset mode. Reset mode will put everything back to default and you could start over from square one. So if you are a user of Iris Vision Live 2.0, don't be afraid to go through those menus, again, pressing, button A on the remote control, and then navigating through with the little joystick here, the little toggle, clicking it up or down to navigate through that menu, and seeing what all those different options are so that you get an idea of what the voice commands are for that particular mode. Example, you stop on brightness. Okay, brightness is a voice command. You can simply say brightness and it'll give you the current value where you're at. Typically it's 6 by default. And if you wanted to adjust it, you could just use the little toggle from side to side and it will adjust your brightness. Or you can get familiar with the number scale after you've kind of played with the toggle, and brightness goes from 1 to 10, for example. So now you know brightness is a voice command. Now you know that the max is 10, and you can say brightness plus any number between 1 and 10 as an example. So there's your coach's tip. Dr. Grandella, please let us know where we could find you. We want to know where your office is. Are you online? Do you have an online store, or is it just, a physical building that you have?
Well, we've got all of it. And I do want to add in one of my favorite things about the Live 2.0 is the
Mhm.
ease of the voice command. So every time I demo it, I'll start people with the physical touches and then I'll go, well, yeah, but what if you wanted to jump from Zoom 9 to Zoom 2 because somebody's passing you a bowl of popcorn during the movie and you're too
Right.
zoomed in to see the pop? Well, you just pull the trigger and Zoom 2, and it's so easy, especially
Yep.
if somebody has poor dexterity to move those buttons. Just to pull the switch, that you've only got to move one finger for that. But
Yes.
we do have an online store, so you can find us at viewfinderlowvision.com. So we have on our store almost all of our products. Sometimes we get a new one and it's not up there yet. You will find some resources on our page, a lot of the Arizona nonprofits, things like that. We have an Arizona resource directory on our webpage, and you'll find all of our locations there as well. Our main offices are in Mesa and in Phoenix. In Mesa, we're at the Viewfinder Mesa office on Alma School Road and Baseline, so 1830 Alma School. In Phoenix, we're on Northern Avenue at the Foundation for Blind Children. So when you walk in the doors of the Foundation for Blind Children, we are immediately behind the reception in the low vision clinic there. We are also going once a month to Prescott and to Tucson. In Prescott, I go to Rummel Eye Care, Dr. John Rummel's office. We're usually up there on a Friday. And then in Tucson, we also go typically on Fridays to the Arizona School for the Deaf and Blind. So we're on campus at the school. So you'll have to pull into the visitor parking, and we usually call you on the phone and walk you in. We're kind of in the middle of the campus. So once you've done it once, you know where it is, but the first time it's kind of tricky.
Awesome. Thank you. And so now we're going to go ahead and wrap up with Q&A. Yunjin, do we have any questions in the chat box?
Not yet, but I just asked people to share what they want to know. So we should wait
Awesome.
for like a couple minutes.
Sure. Yeah. We'll wait a couple minutes and see if anyone has any questions. Don't be afraid to go ahead and ask either me or Dr. Grandella any questions that you might have. We'll try to answer them to the best of our knowledge. And we definitely want to make sure that everyone out there is aware of Iris Vision. If you have it, please definitely call in to customer support if you want a coaching session or if you just have basic questions. Customer support will be able to help you either set up your coaching session or answer any of those questions. If you are not a user of Iris Vision, you can absolutely call in and get some information about it. If you're in the Phoenix area, please do go visit Dr. Grandella's office. I've been there myself, and the staff is amazing. So definitely go check them out if you're in the Tucson area, or if you're not in Arizona, check out his website. Dr. Grandella, you want to mention the website one more time?
Yeah, it's www.viewfinderlowvision.com. Or if you just Google Viewfinder Low Vision, you'll find us.
Awesome. Any questions, Yunjin?
We have one question.
Okay.
Actually, this is for you, Myrna. Why would someone choose Inspire over Live 2.0?
Well, it just depends. All of our products, are geared towards certain things. Now, original live is discontinued. Okay, and Inspire actually is on the way to being discontinued, but I can definitely tell you that if you want to try out Inspire versus 2.0, you do want to make sure you are at the beginning stages of sight loss for that. It's awesome. It looks a little more like sunglasses, so that tends to be uh, a product that most people want to kind of go towards because of the 2.0 looking like a VR headset, a little bit bulkier. But if you have
To know about GA.
if you have sight loss that's progressed a little bit more, you might be a better fit for 2.0, but absolutely talk to one of our sales reps and they can help guide you towards which product is best for you. And as far as the VA, I heard that question come through. Um, if if you are qualified to participate through the VA, your representative should be able to help you there. Your VIS should be able to help you and see if Iris Vision is a vendor for that particular VA. I know that we do have some partnerships with some of the VAs, but not all of them. So definitely talk to your caseworker, your VIS, and see if Iris Vision is offered through your VA.
Sorry, my question was for the doctor regarding GA, the advanced form of dry macular degeneration.
Oh, sorry. Go ahead, Dr. Grandella.
My fault.
It's okay.
What was the whole question, if you would, again?
I'd like to get a better definition of GA.
Okay. So GA stands for geographic atrophy, and that's the name given for advanced stages of dry macular degeneration. So we had said that dry degeneration is a buildup of waste material that then causes degeneration of the retina. When that gets big enough to a substantial area, we can look into the eye and kind of see a cutout of where the atrophy is happening. So it looks often like a political state on a map. It looks geographic. We get that same kind of presentation in other conditions as well, but that moniker is kind of stuck around for the dry form. And so when a doctor hears that, we know right away that it's the dry form. We know that it's advanced. We know this is somebody who's probably using eccentric fixation or looking off to the side to use their side vision to help them. In some cases, that atrophy will occur a little bit outside of the very center of vision, and it can form kind of a C-shaped pattern. Usually by the time we call it geographic, it has filled out the whole C, and we just have a solid chunk of vision that's missing.
Okay, yeah, because that's what my ophthalmologist has told me. My dry macular degeneration is advanced to GA. So I still have everything blurry in the center, but of course on the peripheral it's clear. Are there any kind of clinical studies or anything being done to address this issue?
Well, that's a great question. So last year, a medication did come out for the dry form of macular. It's called Syfovre, and there's an alternative called Izervay. These are both ocular injections that are specifically for geographic atrophy. Now, there has been some hubbub about this because these came out and they were only about 20% effective, but it's a monthly or bi-monthly ocular injection. So for some people, that wasn't a high enough percentage for the amount of stress you're going to have to go through to get a shot in the eye. But the bigger concern, I think, was they also found that it increased your risk of going from dry to the wet form. So I saw a lot of retina specialists just through our mutual patients who were saying, no, we're not doing those shots. It's and not really making anything better. But then I have seen some retina specialists, especially now that it's been over a year. It came out March of 23. Been over a year, they've done a little bit more research into it and found people who've had an effective result where they haven't progressed as much by having that injection. So that's actually out and active. You go talk to your retina specialist, they can tell you if you're a candidate for that or not. So if it's your primary ophthalmologist has told you you have GA, you should be referred to a retina specialist to see if Syfovre or Izervay would be a good choice for you, and have them do that whole discussion of your benefits, risks, and disadvantages of doing it. As far as clinical trials going, there's a lot of studies ongoing about macular. I don't know of anything on the top of my head that they're doing outside of what I said University of Colorado is studying as far as retinal transplantation. If that would work for Stargardt's or similar condition, I would also expect it to work for GA.
Thank you,
Awesome.
Doctor.
And
Thank you. And last question for you is, what about stem cell research? I heard there was some research going on where they were injecting the stem cells into the back of the retina.
So there's been a lot of studies in stem cell for all kinds of different conditions because a stem cell essentially is a cell that we could stimulate to grow into any other kind of cell. To my knowledge, none of the clinical trials, whether in the optic nerve or in the retina, that have injected stem cells were very effective. I've yet to hear one of. I had a few patients who participated that saw big results, but that's kind of what University of Colorado is doing, is that they're using cells to then grow in a petri dish a retina that they could then transplant in. So they're not taking it from a donor person, they're actually growing a new one and implanting that. And so they've got quite a bit of study they're doing as far as how to grow that effectively, how to implant it, how to make it because your macula is not just retina, it's specialized retina. And the retina is not just neurosensory tissue, it's specialized neurosensory tissue. So they've got quite a while that they need to figure out how to induce it to specialize itself so much to get back to the level of function that you had before this condition began.
Oh, very, very informative. Thank you very much.
Thanks, sir.
Awesome. And for anyone who is interested in any kind of current clinical trials happening, a really awesome resource is clinicaltrials.gov. You can go
That's
to
great.
that website and even specify what type of clinical trial you're looking for, or maybe you're a particular eye condition, to see if there's any clinical trials going on. So that's a really reputable site to go to, is clinicaltrials.gov. So with that, Dr. Grandella, we are at the hour. So again, I appreciate the time you took to chat with us today. If we didn't address your questions, please still submit your questions, and we'll get back to you either in the comments below or via email. Okay, so if you didn't get your question asked, or maybe you think of something later on, go ahead and put it in the comments below or send it in as an email. All right. Well, thank you
Myrna.
very much. Yeah, thank you so much. And hopefully we'll have you again in the future
Take care,
on the
everybody.
show. Yeah.
Okay, Mirna, we have one more question from Miriam.
Okay.
Okay, does your product help with night vision? My son likes to go out himself at night with friends.
Iris Vision can help a little bit with that. I've had people who have, that kind of night vision, sight loss, and they've been amazed as to how it is possible that they're seeing with our device on, and it's kind of dark. So, but it depends. Everybody's different. I've had people very successful with it and very much in awe about how much they can see, and they know that it's dark. And then I've had other clients who try it and it just doesn't work. So it really depends on how far your sight loss is and what type of condition you have. So I'm sorry that's not a direct answer, but I can tell you that sometimes people have had a very positive experience, seeing with our device in the dark when normally they can't see in the dark.
Miriam wants to know, how does it work to try it?
Oh, sure. That's really easy. You just call in to that 855-207-6665. Press 1 to speak to a sales rep, and they'll give you an idea of how you can have that 30-day trial, because we do offer a 30-day trial. So they can give you more details on that for sure. And also make sure that your son, I believe, right, Yunjin, it was her son, Miriam's son.
That's right.
Make sure your son is a good fit for the device. So they can help you with that.
Thank you, Mirna. You have answered all the questions.
Awesome. Okay, well, thank you so much. And we will catch you on the next Coach's Corner, guys.